Hello, my name is Amir. I'm pleased to say that I'm a dental surgeon. I'm actually a little dentist, working in a little practice on my own in a small town called Havant in the United Kingdom, and I'm here to talk to you about congenital heart disease. To you, a budding dentist, a midwife, a dentist, a therapist, anyone. That is, you and I, as dentists, have been trained to learn virtually all there is to know about cardiology and congenital heart disease. Not only because some of our patients may have been born with congenital heart disease, or some of our patients may go on to give birth to a child with a congenital heart disease, but because previously some forms of congenital heart disease pose the risk for infective endocarditis. And since you and I have the ability to produce this lesion, we should have known all about it. Personally, and having practiced dentistry for a number of years, I think we need know very little about this, except the following. And except to know that it is quite common. That is 6 to 8 kids per 1,000 born in the United Kingdom. That is 1 in every 160 kids. Up and down the road in these various maternity wards are born with some form of a congenital heart disease. I'm very pleased to say that in the vast majority of cases, this is of a minor importance, a minor occurrence. You recall me telling you previously that many kids, many babies, many patients are born with a bicuspid instead of a tricuspid aortic valve. That doesn't usually matter at all. But it is a congenital cardiac disease and therefore worth mentioning it to you. Again, you and I are both world experts on this one, mitral valve prolapse. Following my talk to you about valvular disease of the heart. And you recall me telling you that tall, thin, flexible, athletic type girls are born with a mitral valve which is too big. It may degenerate and become floppy and actually prolapse into the left auricle. These patients were important to recognize previously because they pose the risk for infective endocarditis and ought to have been put on prophylactic antibiotics. But these patients with a mitral valve prolapse no longer pose a risk for infective endocarditis following the NICE report by the NHS, the National Health Service in the United Kingdom. So these are of minor matters and minor importance, and minor congenital heart diseases. And if there are minor congenital heart diseases, then there obviously must be some major ones as well, and I'm afraid there are, and I'm just going to mention you their names and just tell you a little bit about them. But you should essentially realize that the major congenital heart diseases are divided into 2 big groups. In one big group, our patient is cyanosed and blue, we have a blue baby. And in the other, our patient is not cyanosed and is not blue. So let me first, before I go on to talk to you about the major congenital heart diseases, let me just briefly explain to you why patients with congenital heart disease are blue. Or put in other words, why is it that a baby who's got a hole in the heart as big as this is not blue? Well, in order for me to do that, I need to talk to you very briefly about the basic anatomy of the heart. And I'm going to start by telling you that the heart is a pump, but it's actually 2 pumps and composed of 4 important chambers. The collecting chambers, the left and right auricles which sit on top of the heart, and the pumping chambers, the engines, the left and right ventricles. If you were to take a chest x-ray and look at the heart from the front, you will notice that the major piece at the front of the heart is formed by the right ventricle. The right ventricle that is pumping deoxygenated blood into the lungs for oxygenation. The right border of the heart is formed by the right collecting chamber, the right auricle, The left border of the heart is formed by the main pumping chamber, the main engine, the left ventricle. The left auricle is not visible from the front because it lies at the back of the heart. Now, for simplicity, I want you to forget this anatomical arrangement, and I want you to build these 4 chambers in a square arrangement in your minds, so that we have the right auricle and the right ventricle, and we have the left auricle and the left ventricle in a square arrangement, so that you can see that venous blood, dirty blood, is on the right side of the heart, and clean arterial blood is on the left side of the heart. The right ventricle pumps that deoxygenated blood through the pulmonary arteries into the pulmonary circulation and into the lungs for oxygenation. All that clean oxygenated blood is then returned and collected by the left auricle. The left auricle then forwards it onto the left ventricle. The left ventricle is anxiously waiting to fill up, and upon doing so, pumps that oxygenated blood into the aorta. The aorta accepts the oxygenated blood and distributes it to the rest of the systemic circulation, the coronary artery, the subclavian, the carotid, the vertebral, and so forth and so on. And this is the normal situation we all have. 2 hearts working together, hand in hand, side by side, day after day and night after night for the rest of your life. We are not blue, because oxygenated blood is being pumped by the left ventricle into the aorta. So let's now take this situation. We now have a hole either between the auricles in the interauricular septa, or we have a hole between the ventricles in the interventricular septa. I hope you can see that the oxygenated blood on the left side is at a far greater pressure than the deoxygenated blood on the right. We are dealing with systemic blood pressure. The pressure on the left side is perhaps 4 to 5 times greater, 100 millimeters of mercury mean. And therefore, there will be a tendency for oxygenated blood to go from the left to the right. And the same will pertain with the atria. This we call an auricular septal defect, and this we call a ventricular septal defect. I hope you can see that this is not a normal situation. This is not a normal heart. There is a hole in this heart, but our patient is not blue, because oxygenated blood is being pumped by the left ventricle into the aorta. Patients with an uncomplicated ASD or an uncomplicated VSD are not blue. So what makes our baby blue then? Well, 2 things. Here we have our hole in the heart again, but here we've done something on the right side that is going to increase the pressure on the right side. And that something is to stenose the pulmonary arteries, in particular the pulmonary valves. So these patients have congenital pulmonary stenosis. That increases the pressure on the right side of the heart, and the shunt now reverses, and instead of oxygenated blood going from the left to the right, now deoxygenated blood, desaturated hemoglobin is going to go from the right to the left and end up in the peripheral circulation. And it is the fact that you have desaturated hemoglobin in your peripheral circulation is what makes you cyanosed. And it is reckoned that you need 5 grams of that before you appear blue clinically. We normally have 15 grams per 100 ml. If a third of that is desaturated, you will look blue clinically. The second thing we've done is we've shifted the position of the aorta. The aorta, instead of exiting from the left ventricle as it does normally, it now rides across both ventricles, so that desaturated hemoglobin, desaturated blood, is being pumped directly by the right ventricle into the aorta. So pulmonary stenosis will make you blue, but an overriding aorta will help you go bluer. So if you increase the pressure on the right side of the heart, you can reverse this shunt and make our patient blue. And that's what happens with patients with congenital cyanotic heart disease, they have a hole in the heart plus a lesion in and around the pulmonary arteries which stops the blood going into the lungs and therefore shunts across and lands up in the peripheral circulation and make our patient blue. And now that I've explained why patients with congenital heart disease are blue, let me go on to talk to you about the major congenital heart diseases. And if you recall, and I told you earlier on, that the major congenital heart diseases are divided into two big groups. In one big group, our patient is cyanosed and blue. We have a blue baby. And in the other, our patient is not cyanosed and is not blue. So let me first deal with the ones where there is no cyanosis, where our baby is not blue. So these babies must have an uncomplicated auricular septal defect or an uncomplicated ventricular septal defect, an uncomplicated ASD and an uncomplicated VSD. And that immediately reassures us. When we look at the list, the first one you see on that list, Acyanotic congenital heart disease, is a ventricular septal defect, a VSD. A ventricular septal defect is quite a common. Acyanotic congenital heart disease. And why is it of importance? Well, it's important for two reasons. Firstly, because these patients with a ventricular septal defect previously posed a risk for infective endocarditis and ought to have been put on prophylactic antibiotics. However, in light of the extensive research and the good work carried out by the NHS and the NICE report in 2014, the NICE guidelines, patients with a ventricular septal defect no longer pose a risk for infective endocarditis and do not need to be put on prophylactic antibiotics. If you have a VSD, a ventricular septal defect, the oxygenated blood is going to go from the left to the right, and that puts an enormous load on the right side of the heart because it's got its normal blood flow to deal with plus that of the shunt's blood flow. And the amount of blood going through the pulmonary circulation may be several times more than the amount going through the aorta. The other thing that happens sometimes in a patient with a VSD, with a ventricular septal defect, is that the patient can reverse their shunt. I told you previously that if you have congenital pulmonary stenosis, that will increase the pressure on the right side and the patient can reverse their shunt. But these patients with a ventricular septal defect, because of the large pulmonary flow, may develop an obliterative arthritis of all the small vessels of the shunt, and that increases the pressure on the right side, and the patient can then reverse their shunt, and then the patient who was previously not cyanosed and not blue can become so. This you will hear from time to time and is referred to as the Eisenmenger complex. How do you make a diagnosis of a ventricular septal defect? Well, that's easy. If there is a hole and a shunt and that is being pumped by the left ventricle, it's going to make a noise as it goes through the hole in the heart, and there will be a murmur. And if there isn't a murmur, you can pick up this defect by the Doppler ultrasound, or if you like, you can put a catheter in the heart and show that the chambers on the right side of the heart, which should have desaturated hemoglobin, deoxygenated blood, have a higher oxygen content because of the flow from the left side. So that is its importance to you. Normally patients with a ventricular septal defect are not cyanosed and are not blue unless and until they develop this Eisenmenger complex. Blood flow through the lungs may be tremendous, and you can pick that up with a chest x-ray showing very large pulmonary arteries. And if there is a murmur, you can pick that up by the Doppler ultrasound. This is easily repaired surgically, so you close off the VSD. If you are a dentist and they came to you for dental treatment, if you are a doctor and they came to you for surgical procedure, a nurse previously Patients with a ventricular septal defect ought to have been put on prophylactic antibiotics. However, in light of the NICE guidelines in 2014, patients with a ventricular septal defect do no longer pose a risk for infective endocarditis and do not need to be put on prophylactic antibiotics. Previously, it was thought that there was a risk, not necessarily because there was a valvular lesion, but where that ventricular jet of blood impinged on the opposite side of the heart, on the lining of the heart, on the endocardium. That's where it was thought that injury could occur and infection or infective endocarditis could start, but not on the valve. The second sort of acyanotic congenital heart disease that there is called an auricular septal defect, an ASD, and that is precisely what you see on that list, the second form of acyanotic congenital heart disease. But there isn't much more I can tell you about an auricular septal defect that I haven't already talked to you when I was talking to you about a ventricular septal defect. Patients with an ASD are normally not cyanosed and are not blue unless and until they develop this isomega complex. Blood flow through the lungs may be tremendous, and you can again pick that up with the chest x-ray, showing very large pulmonary arteries, or if there is a murmur, you can pick that up by the Doppler ultrasound. Or if you like, you can put a catheter in the heart and show that the chambers on the right side, which should have desaturated hemoglobin, deoxygenated blood, have a higher oxygen content because of the flow from the right side. This is again easily repaired surgically. The risk of infective endocarditis is small. Even prior to the NICE guidelines in 2014, patients with an ASD did not need to be put on prophylactic antibiotics. However, in light of the NICE guidelines, patients with an auricular septal defect certainly need not be put on prophylactic antibiotics. Probably because the pressure by which the blood goes from the left to the right is much smaller. You're not dealing with ventricular outflow under high pressure, but with the left auricle, which doesn't have a jet effect and will not damage the endocardium on the opposite side of the heart. The only other congenital heart disease that is acyanotic normally, but which again can develop this Eisenmenger complex, is called a patent ductus arteriosus, a PDA, and that is precisely what you see, third one on that list, a patent ductus arteriosus. Now that is of some importance because it's the connection between the aorta and the pulmonary arteries. It goes directly through. The pressure in the aorta is obviously much higher than the pulmonary artery, so the flow is normally in that direction. We all have a patent ductus arteriosus before we are born. And what we do is we close it off when we are born, when the lungs begin to function. I said that's what normally happens. In some patients, this doesn't happen. And if it doesn't, then you're left with a large fistula between the pulmonary arteries and the aorta. And that puts an enormous load on the right side of the heart because it's got this normal blood flow or this vast blood volume from the right ventricle and this important contribution from the aorta. And if you were to listen to these patients, you will hear a murmur arise, and it lasts throughout the whole of the cardiac cycle, which is sometimes called the machinery murmur. Shh, 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 this sort of noise. Or if you like, you can put a catheter in the heart and show that the chambers on the right side, which should have desaturated hemoglobin, deoxygenated blood, have a higher oxygen content because of the flow from the aorta. Or if you like, you can pick this defect up by the Doppler ultrasound. If they came to you for dental treatment or surgical procedure previously, patients with a patent ductus arteriosus pose the risk for infective endocarditis and ought to have been put on prophylactic antibiotics. However, In light of the NICE guidelines in 2014, patients with a PDA, patent ductus arteriosus, no longer pose a risk for infective endocarditis and do not need to be put on prophylactic antibiotics. This is repaired surgically, or it can be treated surgically by closing up the ductus itself, and this usually happens in the aorta, just below the left subclavian artery. So there are three quite important acyanotic congenital heart diseases: a ventricular septal defect, an auricular septal defect, and a patent ductus arteriosus. Previously, these patients posed the risk for infective endocarditis and ought to have been put on prophylactic antibiotics, but patients, in light of this NICE guidelines, no longer pose a risk and do not need to be put on prophylactic antibiotics in 2015. You are not blue. These patients are not cyanosed. These babies are not blue. You are not blue if you have a hole in the heart, unless and until something stops the pulmonary flow. And that could be congenital pulmonary stenosis, or it could be the Eisenmenger complex, by which you form and occlude all the small vessels of the shunt and therefore increase the pressure on the right side and reverse the shunt. You obviously make sure that if you have an Eisenmenger complex, you want to treat that. Well, you can't do that by closure of the shunt. You need a new heart and lungs. If you have an Eisenmenger complex, it would be an indication for heart-lungs transplant. Right. If there are some acyanotic congenital heart diseases, then there obviously must be some cyanotic ones as well, and I'm afraid there are. And these are the ones you read in the newspapers. They're called blue babies. They're born blue. These patients, if they have an auricular septal defect or a ventricular septal defect, an ASD or a VSD, must have something else in order to make them blue. And the one that you probably all heard of and know of is called the tetralogy of fallot. Tetralogy means four things, and here they are. The first part of that tetralogy is that the patient has a VSD, a ventricular septal defect. That wouldn't make you blue, because oxygenated blood is simply going to go from the left to the right, and therefore oxygenated blood is still coming out of the aorta. The second part of that tetralogy is that patients have pulmonary stenosis. That will make you blue because it will increase the pressure on the right side of the heart, and the shunt now reverses. And instead of oxygenated blood going from the left to the right, now deoxygenated blood, desaturated hemoglobin is going to go from the right to the left and end up in the peripheral circulation. And it is the fact that you have desaturated hemoglobin in your peripheral circulation is what makes you blue. And it is reckoned that you need 5 grams of that before you appear blue clinically. We normally have 15 grams per 100 ml. If a third of that is desaturated, you will look blue clinically. The third part of that tetralogy is that they have an overriding aorta. The aorta, instead of exiting from the left ventricle, as it does normally, it now rides across both ventricles, so that desaturated hemoglobin, deoxygenated blood, is being pumped by the right ventricle directly into the aorta. So pulmonary stenosis will make you blue, but an overriding aorta will help you go bluer. And the fourth part of that tetralogy is that they have right ventricular hypertrophy. But that's unimportant. I mean, and it's not surprisingly, if you have congenital pulmonary stenosis, you're bound to have right ventricular hypertrophy. But I think old Fallot was looking around for something just to make it 4, and he put that there. But that is unimportant. A ventricular septal defect is important, but that wouldn't make you blue. Pulmonary stenosis is important and will make you blue, and an overriding aorta will help you go bluer. But how do we pick patients up with Fallot? Well, that's easy. Because they're born blue, they are blue babies, and they have finger clubbing. You recall me telling you previously there are 2 cardiac lesions which produce finger clubbing. We've had them both now. One of them is infective endocarditis, and the other is any form of cyanotic, congenital or cyanotic heart disease. A condition in which there is expansion of the distal compartment of the fingers. So if you held them sideways, you lose the angle between the nail, which is this thing, and the nail bed, which is behind it, the thing behind it. There is normally an obtuse angle. That gets flattened out, and there is soft tissue expansion of the finger so that it looks like the end of a drumstick, and that is called finger clubbing. There is a big right ventricle because it says so up there, and because I told you earlier on, if you have congenital pulmonary stenosis, you're bound to have right ventricular hypertrophy. Or you can pick this defect up by the Doppler ultrasound, or you can show that there is desaturation. If you put a catheter in the left ventricle, you can show that there is desaturation. The risk of infective endocarditis with fallot tetralogy is small. So patients with fallot do not need to be put on prophylactic antibiotics. This can be treated surgically. If the baby is very young, what they do is they anastomose an artery, the subclavian artery, to the pulmonary artery beyond the stenosis so that the lungs are oxygenated. This is called the Blaylock-Calcic procedure. It's not a perfect thing to do, but it's sort of an emergency operation where babies go through in order to stay alive. But in a baby or in a child over the age of 1, this is eminently treatable these days. So you close off the VSD, you put a new pulmonary valve, or you split the one that there is, and you shift the position of the aorta so that it doesn't exit from both ventricles and exits from the left. The right ventricular hypertrophy will disappear of its own accord, and happy days. Mom and dad can breathe again, and our patient, our baby who was previously knocking on heaven's door, can start looking healthy and normal again. And this is called a total correction. Some other interesting things happen when you see patients or babies or kids with fallows. You see them squat. You see them squat on the floor because they are less short of breath by doing that. This is because you can stop and occlude the blood going into the right auricle and take the strain of the heart in that sort of way. You see them squat in order to relieve their dyspnea. The second form of cyanotic, let's work in threes. There are 3 acyanotic congenital heart diseases, an ASD, a VSD, and a patent ductus arteriosus, and there are 3 cyanotic ones. I'm only going to mention you the other 2, just their names, and just tell you a very brief thing about them, because the most important cyanotic congenital heart disease that you'll ever come across is called the tetralogy of Fallot, which I've covered for you already. But let me remind you that there is a condition called tricuspid atresia, where the right ventricle simply fails to develop. And there is an ASD, and therefore deoxygenated blood is simply going to go from the right to the left, and there is a single ventricle. This is obviously not a good situation because there is mixing of the blood, and then obviously therefore our patient is going to be cyanosed. This can be treated surgically. And the third form of cyanotic congenital heart disease that there is called transposition of the great vessels, where you're born with your aorta coming out of your right ventricle and your venous drainage going into your left ventricles. This is obviously not a good situation because you have 2 separate circulations which are completely inappropriate, because you have blue blood, dirty blood all the time in the periphery and clean oxygenated blood in the lungs. This is called transposition of the great vessels, and this can be corrected surgically by an operation called the mustard operation, where they fashion a connection between the right and left auricle to connect the 2 circulations. I hope this has been useful. That's all I have to say about congenital heart disease. And if you like it, please leave me a comment.